البث المباشر ابتدى. تفضلي دكتورة.
السلام عليكم ومرحب بكم جميعا. أنا سعيدة جدا بوجودكم الليلة وشكرا لسودان نكست جن للفرصة دي. أنا الدكتورة ساريا حسن. أنا faculty في Yale School of Medicine هنا في أمريكا. I'm a physician دكتورة in my background بتخصص في باطنية وطب أطفال، وجد سعيدة جدا النهاردة عشان أقدم لكم lecture على management of chronic diseases in the setting of COVID-19 pandemic. فحبدأ البرزنتيشن حقتي حاليا. Okay, فالليلة الأوبجكتيف حقي إنه to really give you an overview على non-communicable diseases. non-communicable diseases زي ما حنشوف هي chronic diseases اللي بقت very prevalent في السودان وفي أفريقيا عامة، وبالذات حسي حاليا في أثناء COVID-19 بقى عندنا challenges كثيرة جدا في management of non-communicable diseases. We're going to talk specifically على management considerations both for managing coronavirus in patients with chronic disease وفي نفس الوقت how to ensure adequate management of the chronic diseases نفسها. We'll talk about the effect of the disrupted care services for people living with NCDs and what we can do and إحنا providers to really think about how to improve the management of NCDs in the setting of these disruptions. And I hope to also give you some resources for the future management of these NCDs. I will say, Anna, كphysician, I am primarily in outpatient medicine. فأنا عادة في العيادة ما جوا المستشفى. A lot of my discussion will really focus on the outpatient care of non-communicable diseases and what we as physicians can do to prevent these patients from getting into the hospital and to keep them as healthy as possible, both from coronavirus as well as from their non-communicable diseases. So let's start by making sure we're all on the same page. So how do we define non-communicable diseases? And you'll see that very often I will use NCDs as the abbreviation for non-communicable diseases. So NCDs encompass 5 disorders: cardiovascular disease, chronic respiratory diseases, cancer, diabetes, and most recently we've started to think about this 5th NCD as the mental health disorders. NCDs have become truly widely prevalent all over the world. They account for 7 out of every 10 deaths worldwide. And it kills about 41 million people every year. This is led by cardiovascular disease, as I'm sure you see in Sudan now, causing about 17.9 million deaths a year. This is followed by cancer, respiratory diseases, and diabetes. Unfortunately, the majority of deaths related to non-communicable diseases today are actually in low and middle income countries such as Sudan. Also, unfortunately, the majority of these deaths are occurring in young individuals, what we call premature mortality. Death from these chronic diseases that occurs before the age of 17. So now that we're all on the same page of defining what non-communicable diseases, and this will really be the focus of the presentation today, how is Sudan doing in the realm of chronic diseases? So Sudan, like many other low and middle income countries, is experiencing what we call an epidemiologic transition. Yani, in the past, the majority of deaths in Sudan were due to infectious diseases, malaria, diarrheal illnesses, lung infections, pulmonary diseases. Lakin really over the last several decades, we've seen a shift from these infectious causes of disease to what we call the non-communicable diseases or the non-infectious causes. So these graphs from the global burden of disease are specific to Sudan. The pink represents the infectious causes of death. The blue represents these non-communicable diseases. This is the year 2000. the one on the top. And you can clearly see that in the year 2000, there were more deaths due to these pink causes, these infectious causes, than there were due to the blue or the non-communicable diseases. Less than 2 decades later, so in 2017, you can already see the shift that is happening, with more deaths now occurring due to these non-communicable diseases than due to the infectious causes. So this is what we call the epidemiologic transition. It highlights that Sudan, like many other countries in sub-Saharan Africa and low and middle income countries, is experiencing this shift. And what's really important is that this shift now means that we as providers, as physicians in Sudan, need to also shift our focus, our infrastructure, our resources, to be more and more dedicated to the management of non-communicable diseases. How bad is the problem in Sudan of non-communicable diseases? So this is relatively old data. This is from 2016. And you can see even then, over half of the deaths in Sudan were due to non-communicable diseases. This is seen right here with this ring chart here. And you can see that those deaths are led by cardiovascular disease, which we'll talk a lot about today. Unfortunately, we are also battling the problem of most of these deaths occurring in individuals who are young, relatively young, below the age of 70, what we call premature mortality due to NCDs. And we are still at around 25 to 30% of NCD deaths are still occurring in the young. So Sudan is faced with a large burden of chronic disease. We have a lot of people who have these non-communicable diseases. And this is really why this topic today of how we manage these NCDs in the setting of coronavirus is so important. So how bad is coronavirus in Sudan today? I am really grateful to Dr. Saria, who's an assistant professor of biostatistics and epidemiology at UIC here in the US, for creating these graphs for me. So these graphs are now showing the number of confirmed cases per 100,000 persons in Sudan, which you see using the blue line, compared to Egypt in orange and Nigeria in pink. And you can see that in Sudan, as those of you who are there now are probably experiencing, that we are starting to see, we are inshallah starting to see the plateauing of the number of cases of coronavirus. Now, Dr. Awalallah wants me to make sure I say that this data is limited, and it is limited by the fact that we have a certain number of cases of tests that are being performed. This data is only as good as the testing that is done. And so it is clearly not the most accurate. It does not reflect the true number of cases, but gives us an indication that perhaps we're starting to see a plateau. This is when we now look at the log of the number of cases. We very often use this to follow the epidemiologic curve. Again, Sudan is in blue, Egypt is in orange, and Nigeria is in pink. And again, if you follow the blue line, you see that we are hopefully have reached our peak and starting to plateau. That to say that we are still faced with an enormous amount of coronavirus in Sudan. This to say that we are still not on the other side of the curve, and that we will continue to see lots of cases in Sudan. And so this conversation today will help us understand how we can manage non-communicable diseases in the setting of this coronavirus pandemic. This is a snapshot from the Ministry of Health in Sudan website, which is a great way to follow. They're very good about updating these numbers daily. To tell you the number of individuals who are infected with coronavirus and the number who have unfortunately passed away. And you can see that at the time I took this snapshot, we are almost at 10,000 cases of coronavirus. Just to really tell you something that you probably already know, but I want to make sure we go through this background just so that it'll inform the rest of our conversation. When we talk about individuals with chronic disease having coronavirus, there's a spectrum of coronavirus infection, those who will develop very mild symptoms and those who will develop very severe disease. So this gives you the first set of figures here all of this from the CDC, gives you a sense of what the common symptoms of coronavirus are. And this is what you have heard, I'm sure, repeatedly. As you probably know, these symptoms will develop 2 to 14 days after exposure, but we have a very large percentage of individuals who can be completely asymptomatic. And it is truly these individuals who are asymptomatic who are thought to be driving the epidemic and the continued transmission of disease. Remember also that fever is not necessarily present in coronavirus, and this is especially true in children. As I had said, there are individuals who develop severe disease, and the table here in the beige shows you what those symptoms of severe disease are. And this is really, as we think about how to counsel our patients with non-communicable diseases, this is what we're worried about. The trouble breathing, the confusion, the chest pain, and the possible hypoxia, which is indicated by the change in color of the lips. Also important is to understand the progression, the clinical progression of coronavirus, because as we think about how to counsel our patients with non-communicable diseases and try to keep them as safe as possible, understanding that if you test positive today for coronavirus and have only very mild symptoms, that does not mean that you're all set, that you're not going to end up getting very sick. Remember that the peak of illness can occur up to a week after the initial symptom onset. So it's really not until you've passed that 10, 12-day mark and are doing okay that we can start to sigh a sigh of relief. And that is also why it's really important, if we have individuals who have non-communicable diseases, who develop some mild symptoms of coronavirus, to counsel them that this could get worse, and they need to be very attentive to that. This is tabled. This slide is really to show you the spectrum of illness and how we define the spectrum of illness in coronavirus, from asymptomatic to mild illness to moderate illness, severe illness, and then critical illness. As I had mentioned before, this talk is not to address the in-hospital management of coronavirus, but I did want to just make a few notes because I'm sure this is on everybody's mind and everything that people are thinking about. As you know, there have been now new recommendations that recommend against the use of hydroxychloroquine. There has been very encouraging data on the use of dexamethasone, and I will review that in a minute because it is of high relevance to our patients with diabetes. Remdesivir is unfortunately a very expensive drug, but has shown some promising results, again, in severe cases. So emphasizing that both dexamethasone and remdesivir as treatment for improving mortality in coronavirus cases are really improving mortality only in individuals who are classified as severe, not those with moderate or mild illness. And there's a lot of talk about serologic testing. Just to say that the vote is still out as to whether or not serologic testing confers immunity. And so at this point in time, there is no recommendation to be performing serologic testing in our individuals, including those with non-communicable diseases. So now with that background and making sure that we're all on the same page, let's shift to discussing non-communicable diseases in the setting of coronavirus. And it's really there are two main points to drive home. So one is that people living with non-communicable diseases are more likely to get severe disease from coronavirus. They are more likely to die from coronavirus. At the same time, people living with chronic disease, if their chronic disease needs are not met, if their non-communicable diseases are not adequately managed, they will suffer morbidity and mortality from their non-communicable diseases. This is why I call it the double-edged sword. While we want to keep our patients with non-communicable diseases safe at home, we must be able to manage their non-communicable diseases adequately. Otherwise, while we might protect them from coronavirus, what will end up killing them is the complications of their NCDs. So what we'll first talk about is that first side of the sword, which is what is the degree of severity of coronavirus in individuals living with NCDs, people living with NCDs. You'll see it abbreviated often as PLW-NCD. So let's first take diabetes. Extremely common. I am sure you have family members, close relatives, friends who suffer from diabetes. If not, you have most certainly seen it in your practices. Unfortunately, as you have heard over and over again, individuals with diabetes have a significantly higher risk of being hospitalized for coronavirus. They have a significantly higher risk of dying from coronavirus. Cardiovascular disease gives a very high propensity of death from coronavirus. 10% of people with cardiovascular disease who get coronavirus will die. This is compared to only 1% of the general population without cardiovascular disease. That being said, there's a very high prevalence also when we look at individuals who have coronavirus, hospitalized for coronavirus, a very high prevalence of them will have hypertension and cardiovascular disease. So again, this highlights why addressing diabetes and cardiovascular disease in the setting of coronavirus is so important. Chronic kidney disease, unfortunately, as we see higher rates of diabetes and hypertension in our population, we have seen a tremendous rise in the amount of individuals with chronic kidney disease. The demands on our dialysis centers and dialysis units has skyrocketed over the last few decades, and that is really a testament to the management of diabetes and hypertension in the country. Unfortunately, having chronic kidney disease independent of underlying diabetes or hypertension gives a 3 times higher likelihood of developing severe symptoms from coronavirus than those who do not have chronic kidney disease. Unfortunately, those individuals also likely have diabetes, also likely have hypertension, and so their risk of dying from coronavirus is significantly high. In terms of pulmonary disorders, asthma is the one that we most commonly see in Sudan, and it is quite common. There's still debate out there as to whether or not having asthma increases your likelihood of acquiring coronavirus. But what we do know and what we've seen here in the US is that there is a fair proportion of individuals who are hospitalized for coronavirus who do have asthma. So we do know that there is some association, and really important for us to be able to adequately manage asthma in the setting of coronavirus. The last 2 non-communicable diseases I want to address in terms of understanding how they're associated with the severity of disease in coronavirus are cancer and mental health disorders. Cancer in particular individuals who are immunosuppressed as a result of their cancer most certainly have a higher risk of developing severe disease from coronavirus. As we know, immunosuppression in and of itself carries a higher risk with any infection. Coronavirus is included in that. However, if you have a past history of cancer, are not currently immunosuppressed, that does not necessarily confer any higher risk. And we'll talk more about cancer later. Mental health disorders are something I will continue to stress throughout this talk, something that we perhaps do not give as much attention to as we should. Really to note that coronavirus has increased the level of stress and anxiety among all our patients. This is even more so among our patients who have non-communicable diseases because of what they hear in the media about the higher risk that they have because of their non-communicable disease. But this also means that those individuals who have underlying depression or anxiety will most certainly be triggered in the setting of coronavirus and the uncertainty of these times. We must be able to address these mental health disorders in order to be able to adequately manage their non-communicable diseases. At the same time, though, we have to acknowledge the really emotional burden that coronavirus has placed on the providers. We must make sure that our providers have some good emotional well-being before we can have them treat others. And so this is really to understand that we are not able to address the severity of coronavirus without being able to address the safety and the mental health well-being of our providers. And this will entail a lot of work on the front lines, which I'll talk more about in a moment. So with this background, hopefully we are now at a stage where we realize that non-communicable diseases confer a significantly higher risk of developing severe coronavirus disease and furthermore of dying of coronavirus. And so now let's talk about what are some of the special management considerations we need to take into account when we manage non-communicable diseases in the setting of coronavirus. Again, we'll start with diabetes. And the most important point to make with diabetes is that hyperglycemia increases the risk of severe coronavirus. A study clearly showed that the level of 10 millimoles per liter has been linked to increased mortality in people with coronavirus. This really makes it very important for us in the outpatient setting, as much as possible, to manage the hyperglycemia in our patients with diabetes. Being able to bring them to euglycemia to keep their blood sugars under control will be the best thing for them if and when they get coronavirus disease. And this diagram here clearly shows that with well-controlled blood sugars, your chance of survival is at 98.9%. If you have poorly controlled diabetes, your likelihood of death is at 11%. So clearly, from this paper that came out in Cell Metabolism, that it is really important that blood sugar be controlled. But unfortunately, it's not that simple, because what we have found is that coronavirus in and of itself promotes hyperglycemia. So COVID-19 increases insulin resistance and impairs insulin production from the pancreatic beta cells. So this results in significant hyperglycemia in our patients who have underlying diabetes. We in the hospital have been seeing more diabetes ketoacidosis than we have really ever seen, especially in our type 2 individuals with type 2 diabetes. So it really becomes a true challenge in controlling those blood sugars. And when we know that blood sugar control is directly related to your likelihood of survival, it becomes imperative that we very aggressively manage those blood sugars. Here in the US, there have been several trials around continuous glucose monitoring that has shown improved effectiveness in managing the significant hyperglycemia that we have in these patients who have both diabetes and coronavirus. If that is available to you, that is definitely an option. That is not something that's always available, however. But the more recent dilemma has come because of dexamethasone. And we'll talk a little bit about what the data and the evidence is around dexamethasone. But as you all know, steroids and dexamethasone in particular induces an increased level of hyperglycemia. So now individuals with diabetes have their underlying diabetes. They have COVID-19 that's causing more hyperglycemia. And now you give them dexamethasone and it's causing even more hyperglycemia. So again, something to note that the aggressive management of those blood sugars is really, really important. But what is all of the hype around dexamethasone? I want to make sure that I at least mention the recovery study in this talk. So this was a study that really rocked the world, I will say. Dexamethasone is cheap. It is a drug that we have all been using for many, many, many years. So it's always nice to find a treatment that is actually affordable and accessible. And what the recovery trial showed, this was out of the United Kingdom, is that for patients with severe disease, so severe coronavirus, dexamethasone reduced the deaths by 1/3 in those receiving invasive mechanical ventilation. That is a significant reduction in death. Again, this is individuals with severe disease. So if you see those who were not in invasive mechanical ventilation but had severe disease, they had a 1/5 reduction in deaths. But you can see that there was actually no benefit in those with mild or moderate symptoms. So really the biggest takeaway here is that dexamethasone is not really for our outpatient use in the clinics. Dexamethasone works in those with severe coronavirus. This is important because as you counsel your individuals with non-communicable disease, and especially those with diabetes, you don't want them just taking dexamethasone. That will make them hyperglycemic, and then that will precipitate them having severe coronavirus, which could have been avoided without the hyperglycemia. While we are on the topic of medications and diabetes, let's address another medication that is really important for us to consider when we talk about the special management considerations in diabetes and coronavirus, and that is of the angiotensin converting enzyme inhibitors, the ACEs and the ARBs. And so this has been a very hot topic of discussion for several months. I believe that we're all now satisfied with the verdict of what to do with these ACE inhibitors and ARBs. But really the information and the data had come out initially from mouse models showing that there could perhaps be a worsening of coronavirus disease in individuals who are on angiotensin-converting enzyme inhibitors. More recent studies you see outlined here have shown that this is actually not the case, that ACEs and ARBs are not significantly associated with mortality. And there's a very recent study that's to come out from Yale that showed that perhaps in the elderly, it actually might confer benefit. So let me just walk you a little bit through the pathophysiology and why there's all this debate around ACE inhibitors and ARBs, and are they good or are they bad? This is a paper from South in Nature Reviews Nephrology that recently came out that had this beautiful schematic explaining the two hypotheses. So the hypothesis on the top, that the RAS inhibition is bad in coronavirus, and the one at the bottom, that the RAS inhibition is protective. So hypothesis one is based on the fact that if you are on angiotensin-converting enzyme inhibitors, you actually have more of this receptor, this ACE2 receptor, expressed on the surface of cells. Now, what turns out to be is that the ACE2 receptor is what the coronavirus uses to actually enter cells and cause destruction. So if you have more receptors, the theory is that you have more virus entering the cells. Now, the counter argument to that is that once this virus enters the cell, the destruction is made by increased inflammation. But what ACE inhibition also does is that it actually stops the process of inflammation and fibrosis. And this is how it is presumed that ACE inhibitors could at the same time be beneficial. So all of this is to say that the verdict is still out, but there is absolutely no reason for the discontinuation of angiotensin-converting enzyme inhibitors or ARBs in patients with diabetes. And as we'll see, this applies to patients with cardiovascular disease as well. The data and the benefits of ACE inhibitors and ARBs in controlling blood pressure, in renal protection, in cardiovascular protection, far outweighs any possibility, albeit data that's not proven, but any possibility of there being a harmful effect of the ACE inhibitors in the setting of coronavirus. So really the strong message here is that these drugs should not be discontinued in our patients with non-communicable diseases. Other drugs that have been really in the news around coronavirus and diabetes has been the DPP4 inhibitors, and I give you some examples of those here, and the SGLT2 inhibitors, which you see also listed here. These are becoming more and more common. The SGLT2, I'm not sure you're using as much in Sudan, but the DPP4s I've definitely seen. And really the argument very similarly has been whether or not it is helping diabetes or not, or helping coronavirus or not, or making it more harmful. And people are going both ways. The problem with DPP4 inhibitors is the blood sugar effects, but there's actually potentially a benefit of DPP4 inhibitors, and there's certain trials that are out, especially with the SGLT2 inhibitors, to see if there's benefit. Now, with the SGLT2 inhibitors, that is the one drug that you should consider stopping in someone who develops significant symptoms of coronavirus. And the reason is that the SGLT2 inhibitors have been known to precipitate diabetes ketoacidosis. And given the significant hyperglycemia that we see in our patients with coronavirus, the last thing we need is a drug on board that precipitates DKA. So that is the one thing that there is a recommendation to stop in the setting of severe coronavirus in our patients with diabetes. Moving on to cardiovascular disease, really the main take home here, we talked about the ACE inhibitors and the ARBs. So in patients with coronavirus, do not stop their ACEs and their ARBs. But really the main point is coronavirus in and of itself gives you a very high risk of cardiovascular events. And these include myocardial infarction, myocarditis, and arrhythmias. So we need to keep this in mind because this risk is obviously heightened in someone with a history of cardiovascular disease. We are still not sure of what the long-term consequences and sequelae from a cardiac perspective are for patients who develop coronavirus, and that's something we'll be monitoring, and really important for us to monitor in patients who have a history of cardiovascular disease, develop coronavirus, inshallah recover from it, but then how do we monitor them moving forward, knowing that there's this higher risk of cardiac injury. In terms of asthma, COPD, and coronavirus, really the greatest challenge is in distinguishing the signs and symptoms of asthma, of an asthma exacerbation, from those of coronavirus, of COVID-19. And one way to do that is to look through that list of symptoms that we talked about initially and see if there are additional symptoms that we don't regularly see in asthma, but are more associated with coronavirus, such as the loss of taste or smell, such as diarrhea or abdominal symptoms, severe headache, fatigue, muscle aches. So that could, sway you to think that this is an asthma exacerbation in addition to coronavirus infection. Be careful of fever. Like I said, in the US here, 27% of children did not have a fever with their coronavirus. And also be careful that there are other viruses that can give you symptoms that are similar to coronavirus and can cause an asthma exacerbation. And we're going to see more of those viruses come into play as we get into the change of season. So all to say that it is complicated. If you have testing available, that is the first thing you do. If it is not, then you're going to manage it such as it is coronavirus and asthma concurrently. How do we manage asthma in the setting of coronavirus? Really, the treatment is very similar to what we do with regular asthma. So steroids are still indicated as they would be in a severe asthma exacerbation. The main and most important thing is that you should completely avoid the use of nebulizers in the setting of an asthma exacerbation associated with coronavirus. The main reason for this is that the nebulizer will further aerosolize the coronavirus, leading to much higher likelihood of infecting everyone around the patient. So nebulization is really not indicated unless you have no other option, obviously, or you are able to isolate the patient completely. And you have some way of really protecting the provider, because the aerosolization will put the provider at much, much higher risk. There have been now several studies that have shown that the use of an inhaler with a spacer is just as efficacious in the treatment of severe asthma as a nebulizer. So given this and knowing this, we really should be able, in most cases, to continue to use an inhaler with a spacer, as shown in this image here. That's really the biggest take-home point for the management of asthma in the setting of coronavirus. Again, I bring you back to this burden of mental health. I want us to be speaking more and more about the mental health burden, specifically in patients with a history of mental health disorder, but really knowing and understanding that patients who have non-communicable diseases are much more likely to experience symptoms of stress, anxiety, and depression in the setting of the current coronavirus pandemic. That also to say that providers, again, we have to make the space and the time to address providers' emotional well-being so that they can continue to manage their patients with non-communicable diseases. In terms of how to address this, we must try to ask about mental health problems, to discuss the importance of emotional well-being. By doing this, we open the space for candid conversations, which will allow us to help the patient manage those mental health disorders. So now that we've talked about how we can better address NCDs in those patients who have non-communicable diseases who get infected with coronavirus, let's now shift and talk about the other side, which is those people who are living with NCDs and how we can, who do not, hopefully don't get coronavirus, but realizing that we need to be able to adequately manage their non-communicable disease. And what we will see is that this has become progressively more and more difficult with the significant coronavirus restrictions that have happened and occurred really all over the world. The World Health Organization, led by the Eastern Mediterranean Regional Office, recently led a rapid assessment of service delivery for non-communicable diseases during the COVID-19 pandemic. What this did was really try to understand the degree of the NCD service delivery disruption. How bad is it? How difficult really is it for our patients in this instance, specifically in the Eastern Mediterranean region? How difficult is it for those patients with non-communicable diseases to access care? So I'll show you here some of the results from that rapid assessment, which is available online, and one of the resources I will list at the end of the presentation. So as you will see, the pink bars here represent partial disruption of NCD service, and the darker color is a complete disruption of NCD service. And the very first one you see is hypertension management, with almost 50% disruption to some degree of delivery of that NCD service. We know very well that poorly managed hypertension, very elevated blood pressures are a very high risk factor for stroke and for cardiac events. Cardiovascular emergencies, you can see we're almost at 30% disruption of those services. Cancer treatment, 42%, and I'll end by just noting diabetes. Because diabetes in particular, as we saw, when we cannot manage that blood sugar, we run into much higher risks of developing severe coronavirus. And you can see the rest of the NCD-related services listed here. Now, what was the cause of this service disruption? If we're going to try to address the service disruption, we need to be able to understand what's causing the disruption. And one of the key things you see here as the top two ones that are noted is the closure of outpatient services for NCDs. So when our government offices, our primary health centers, our family health centers are closed because of the restrictions of coronavirus, our patients have no way of accessing medical care. They have no way of getting prescriptions or refills for their medication. And they have no way of getting medical advice when they start to run into problems with their NCDs. So this is something I'll come back to as a way for us to innovate, to start thinking about in the setting of closure, how we can continue to deliver services to this population. The other thing I want to highlight is that there is definitely an element of fear. So in the setting where people are hearing repeatedly the risk of them developing coronavirus if they have diabetes, if they have heart disease, they are scared. They're scared of getting coronavirus. And what this leads to is them completely avoiding healthcare and healthcare systems. And we are going to have to address this head on if we want to make sure that we're able to address their non-communicable diseases. This is data from the United States, which shows really before our eyes this element of fear. So this is data from the VA, the Veteran Affairs hospitals in the US. The blue line is looking at admissions in the year 2019. Over the same time period from week 1 to week 16, this is in March of 2020, and in March. So the blue line is March 2019, the yellow line is March 2020. So you can clearly see this first graph here is the y-axis is showing the number of admissions, and the x-axis is the number of weeks. So over the course of March, you can see that in 2019, we had a steady rate of admissions of about 15,000 admissions. And you can see that in 2020, there is a significant drop in admissions. So clearly, people are avoiding the hospital. When you look at stroke, the number of people presenting with stroke is significantly reduced. When you look at heart attacks, myocardial infarction, there's a significant reduction in myocardial infarction admissions, and the same with heart failure. The biggest concern here is that these people are staying home, that these people are not seeking emergency care the way they should because of the fear of coronavirus. And the biggest concern here is that these people end up dying at home. So clearly there's a fear factor, and we need to reassure our patients that there is a safe way for them to access care. In Sudan, we know you are all on the ground and have seen this firsthand, that because of the COVID-19 restrictions, there's been several disruptions to our NCD services. There's been clearly issues with provider safety and providers really not feeling safe enough to provide care. But there's also been, as seen in this diagram from this picture from Forbes, disruption in access to medication. and this is a protest by pharmacists in Sudan because of the lack of access to medication. But even in addition to that, our primary health centers and our family health centers that are affiliated with the Ministry of Health have been closed, which has happened all over the world. This is not only in Sudan. My clinic was closed here in the US for a period of time, has been closed to in-person visits as a result of coronavirus. So we know that there's also disruption of services for people living with NCDs in Sudan. Why is this important? Why is the disruption of NCD services so important for us to consider? Well, to start off with, people living with NCDs are facing much higher problems and challenges in managing their chronic disease in the setting of coronavirus. First, they have less access to food. There's higher levels of food insecurity. It's harder for them to access fresh fruits and vegetables. They're less likely to go and line up in lines and go to markets to access food because of the fear of coronavirus. So they're not eating as well as they should. They have decreased access to physical activity. They're not walking to work, walking from work, taking transport. They're not out and about the way they used to be. They have limited access to medication. We talked about the pharmacy disruptions and disruptions in access to medications, but this also means that they're less likely to go to a doctor to get a prescription for a medication or to be able to go to the pharmacy to get their medication from a pharmacy. And the increased stress and anxiety. All of these things make it much more likely that individuals with diabetes, with high blood pressure, with heart problems, with mental health problems, with lung problems to suffer complications from their non-communicable diseases. They're more likely to suffer complications from their non-communicable diseases, but now they're also less likely to get care because our clinics are closed and they have no way of getting a hold of the physician and the doctor. So they have disrupted access to medication, to medical advice, to in-person care and treatment. And unless we address this, we're going to inevitably lead to an increased rate of morbidity and mortality from these non-communicable diseases. So really, the big plug here is to say we need to start thinking outside of the box and start to find ways of still providing care for this population of non-communicable disease patients so that we don't see a rise in death from diabetes, heart problems, kidney failure, and so on and so forth. So the same WHO EMERALD report outlines some of the approaches that different countries in the Eastern Mediterranean region are taking to try to address this disruption in NCD services. So telemedicine, we've all heard about telemedicine and telehealth, a wonderful way to try to provide access to care for patients with non-communicable diseases. Task shifting, remembering that doctors are not the only people who can provide basic care for diabetes, high blood pressure, and heart disease. Why not employ community health workers or nurses or nurse practitioners? The spectrum of Health Alliance providers can be trained to deliver non-communicable disease care. Making sure we have innovative ways of getting access to medication. So diversifying our supply chain so that we have increased variety of ways of getting medication into the country, triaging adequately patients, and redirecting patients to other facilities which may not have been classically facilities that provide care for non-communicable diseases. So really to say that we need to start thinking about ways to reach out to our community of individuals who are living with non-communicable diseases. Those patients, first and foremost, we have to be able to empower them to be able to self-manage their disease. They need more information and more education. For patients with diabetes, with high blood pressure, with heart failure, with asthma, there are certain things that they can do in and by themselves to better manage their disease, to know what to do when they start to develop some mild symptoms and treat it and manage it on their own before it becomes severe. Not everything they can do on their own, but there are very set guidelines of how to self-manage these conditions that we need to be able to empower our patients with so that they know when things are mild and they can manage them and when they need to seek care. We need to be able to address patient fears about seeking care, address the mental health concerns, as I've said now a few times, ensure continued access to medication. So being able to make sure that there are ways to provide prescriptions, that there are ways for these patients to continue to get their medication. Several countries have now instituted home delivery services, so patients don't have to go to the pharmacy, but they use community health workers to deliver medications to the homes of people living with NCDs. Dialysis services must never be stopped, and there has to be ways of ensuring the safe access to dialysis for patients with end-stage renal disease. And finding ways to provide medical advice. It doesn't have to be full telehealth or telemedicine, but some form of accessing a platform where you can discuss and acquire medical advice is really important. And of course, we have to continue to tell our patients repeatedly the importance of social distancing, the importance of wearing a mask, and washing their hands continuously. So is it going to be possible to provide care again in our primary health centers and our family health centers safely? This schematic is drawn from Resolve to Save Lives, which is a cardiovascular network all over the world that has tried to outline how we can safely bring our patients with non-communicable disease back into the clinics. And I'm going to walk you through this. This really pertains to our primary health centers, to our private clinics, similarly. But the dialysis centers and the cancer treatment is very specific, and I'll give you resources on how to address those in a minute. So first, you have patients who are coming in for a visit, and you need to establish triage areas that are outside of the clinic. We know very well that there's less likelihood of transmission of coronavirus outdoors where there's proper ventilation. So in the outdoor area, you first have area A, where you triage individuals who are coming in with concerns for coronavirus. Those individuals go immediately to area C, and then you distance them from everyone else who does not have coronavirus symptoms. Those who do not have coronavirus symptoms and are coming because they have a problem with their diabetes, because they have a problem getting medication for their blood pressure, those individuals go to area B. Those are individuals who do not have coronavirus symptoms. This is an immediate triage so that you can immediately separate individuals who could potentially be sick. Now, once people get to area B and area C, you now have a very specific screening process. You check their temperature. You ask them about a list of symptoms that are known to be associated with coronavirus. You ask them about access and exposure to people who've had a recent coronavirus. And only when they are negative for all of those do individuals in area B be let into the waiting area for patients who have screened out for coronavirus. In area C, very similarly, you are able to triage the patients. In area C, those with a very high suspicion for coronavirus are immediately triaged to a separate area and kept away from those who we're not quite sure yet, but could have coronavirus, but we don't want to put them right next to those individuals who definitely have coronavirus. Again, utilizing the space outdoors. It is difficult with the rainy season coming to ensure that that will always be possible, but the degree to which covered areas outdoors can be kept, that'll be the safest for everybody involved. Now in area B, you now have the individuals, if they have suspected coronavirus, you're going to send them over to the area for suspected coronavirus. Otherwise, they come in to this routine care for primary health care patients. All of this really requires a couple of things. One is adequate protective personal equipment for providers. So providers who are going to be involved in this triage process need to be able to protect themselves. And so that is definitely a must. The requirement that everybody wear a mask, even if it's a cloth mask. We now know that cloth masks are adequate. So individuals with cloth masks, really everybody should be asked to wear a cloth mask. This resource will be in the list of resources, but it's a nice way to start thinking about how we could potentially reopen our primary health centers or family health centers or private clinics to be able to provide care for individuals with non-communicable diseases. I mentioned the dialysis centers and cancer care as special case scenarios. These are two resources we recently put together with the Pan American Health Organization that outlines in detail how we can think about safe access to dialysis and safe access to cancer treatment. I mentioned this briefly, but I want to just reiterate that the safety of our providers really must always be a priority. In order for our providers to be healthy enough to provide care, in order for our providers to be healthy enough to want to provide care and continue to provide this really immense and amazing service that we deliver on a daily basis, we really have to keep their safety as a priority. So adequate PPE is essential. You know, we have unfortunately witnessed a rise in attacks against providers, and their safety must be ensured. We need to ensure that providers who fall ill have access to treatment. You know, I'm much more likely to come and work knowing that I'm at risk if I know that if I do fall sick, I'm going to be cared for. So having access to treatment, having access to compensation for lost days of work are all really important and really the least we can do for providers. And addressing stigma. There's stigma on multiple levels when it comes to coronavirus. And there have been several talks around this, but it's really important to continue to address it. So lastly, I just, I'm sure these slides will be shared with everyone, but really to outline that there are several really amazing resources that I've drawn a lot from for this presentation today, freely available on the internet. The World Health Organization branch in Sudan has done amazing work on coronavirus and wonderful resources there. Resolve to Save Lives, a global community for cardiovascular health, has wonderful resources for the management of non-communicable diseases. The WHO has really spearheaded the conversation around non-communicable diseases in the setting of coronavirus. They have several documents outlining how to address disruption of health services, and their website is extremely informative. Both at the Eastern Mediterranean Regional Office as well as the Pan American Health Organization. So in summary, I'll end by saying that people living with NCDs are more likely to get severe disease and die from coronavirus. People living with NCDs are more likely to suffer complications of those chronic diseases as a result of the COVID-19 restrictions, as we saw. NCD-related service delivery has been disrupted all over the world, and this includes Sudan. Ensuring the continuity of service safely, we have to do it safely, for all NCDs is really imperative to reduce the very disastrous and concerning rises in NCD-related morbidity and mortality worldwide. To do this, we must address patient fears and barriers to care. We must address provider fears, provider stress, anxiety, and depression. And we must reduce the stigma around COVID-19 and continue to find innovative ways of delivering care without having necessarily our clinics open all the time. So with that, I'll end, and I see we have a few minutes left for questions. Wallahi shukran jazilan. Thank you for your attention. This is a topic clearly that's very dear to my heart, and I hope I'll be able to contribute in other ways to help this fight in Sudan, inshallah. So with that, I'll stop my share and see if there are any questions. Okay, so I see on the chat here that there are no further questions. And so with that, I'll end. Again, thank you so much. شكرا جزيلا للفرصة. شكرا لسودان Next Gen. تحياتي لكم كلكم. شكرا.